where you're gonna take your exam. So this is the study guide from them. Um, One of the ways that you can get this is by paying it. Um, I have it, so I'm gonna kind of give it to you guys by sharing with you guys what it is. And then after, what we can do is take one. I have a few exams, practice exams that I can do with you guys. So it's simple. It's just uh, that you don't have it. So I think the best way to practice is practicing the the different things that we have for it. So you'll see how so it gets easier as we see the things pop out. So
Uh,
many, yes.
sorry. No, I'm sorry. You can continue. I thought you were done.
No, go ahead, go ahead.
I was gonna ask, are we ever gonna go over the practice one that you gave us?
Yes, yes, we will. We will.
Okay. I was just wondering because I really want to see how many I got right and wrong.
Let me see. I have it. I have most of them now. I think I just got one more today before we started the class. So yeah, today before the class started, I got one. I think that was maybe the one that was missing. But yeah, like I just got one today that I was missing. So but yes, just please follow this section. This is the most important practice that I can give you because it is based on the NHA. But I want you to just follow the things. It has a different way of showing. I'll show you how the questions are going to be, and that's gonna be later. But we're gonna do 4 modules. This is how it's divided into 4 modules. I'll try to do one module at a time, and then um, be the last 2 modules together. So we'll take like almost up to the end of this week. We'll check all the things that we've done before the end of the week, and then we'll move to kind of a last uh, rundown before the exam. No, before the practice exam. You still do have a final exam and one more 2 more practices to do. So this is the last section where we're going to cover everything together. Okay, everything, all the things that we've seen. Let's see how many you have. 8. So this is let's see. I want to make sure that you can see what I'm saying. Okay. So this is the NHA, the National Health Career Association. It is the people that are going to give you your certification, the ones that are going to give you the exam. The exam is going to be in this platform. Another thing that we need to do is uh, set up the exam and register for the exam as soon as I get the okay uh, from from the college, from the department um, for testing. That we have our dates. I'll let you know, and we'll do it together. So, like I said, each section here is gonna be one module, and the module is gonna be divided. 'Cause, like I said, it's based on the NHA. So, 1 module is gonna be 1 hour. 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 information, for example, the glossary, the terms, I'm gonna give them to you um, in a document. So it's kind of a same thing of the terms that we looked at before, but I'm gonna give you the four that are included here in a document. So I'm gonna upload them tonight after the class. I like to go over them just to make sure that you remember. But most of the things that we have here we've seen before. It's just that they have an extra definition for it. It has a few other things, but the main thing is that if you follow this, you will be in line with what they want and the way they want to show it. So we have some icons that are gonna be here next to them. Whenever you see this, it's gonna be something that has to do with medical terminology, and you see something like this is gonna be electronic health records. This is professionalism, and this is the one that matters for us. Is the money sign. It's the revenue cycle. So the revenue cycle is going to be the thing that matches uh, the how the claim goes from being created all the way to getting paid. As we move along, there's some things that are called the mentors. There's two little characters that they have. One is Billy, one is Cody. Billy will be the one that talks about billing, and Cody, the one that has to do with coding. So whenever you see these two little characters, they're gonna be helping you understand if it's coding or if it's billing. There's a few things. I'll try to get as much as this to you guys in a document. So be aware that this is going to be there. So I'll try to get uh, one at a time. So I'll let you guys know. Um, so again, most of the information. This is an introduction, but most of the information is gonna have things next to it. This is for you guys to know that the current procedural terminology or CPT comes from the American Medical Association, and anything that they have comes from CMS. So you need to make sure that you know that just in case uh, you get some of this in a form that you're going to copy. So the first thing that we need to go over is the revenue cycle. I'm gonna click on this picture, and this picture is gonna get a little bit bigger. Let me see. That's too big. Maybe here. Yeah. So the the billing portion of this has to do when the patient checks in all the way until payment. In between, we're gonna have different things, and one of the things that we're gonna have is the codes. So when we talk about the revenue cycle, we talk about this. We talk about a map that starts around here, okay, the patient check-in, and it moves along that line to these different things: utilization management, health encounter, coding, patient checkout, billing, paid adjudication, payment, appeals, and then more payment. So technically, we start a patient check-in, right? But for your book, the first thing that we have is registration or and scheduling. Now, in real life, the revenue cycle does not really start there. It starts when the encounter happens, so it's a little bit further down the line. But for the purposes of our exam, when you register a patient and you check that they have the insurance that we take, and they have all the things that they need, then that's where things kind of start. So we're gonna go over this in this unit over all of the things. We will be moving through this little map, little by little. So we're gonna do registration, then check-in, then utilization management, and all the way until you finish to any payment or collections. So this is basically what we're trying to do here. So I want you to just every time you see this, you'll see where we are uh, in this little map. Okay, and I like to call it a map of like a roadmap to to the whole billing cycle. Okay, so here in between, we're gonna have these terms. I'm gonna click on them every time they have they are on bold or have underline, and it says account receivable. We already talked about account receivable being the money that comes in, and that money comes from the services that are performed for the services that are provided or rendered. So the best way to remember is payment for the things that we did to whatever we did to the patient. So whatever we did to the patient is gonna be paid, and that will have an entry in the accounts receivables account or in the money that's coming into the office. So in order to do that, well, then we need to make sure that we have that money coming in all the time. And the way that we have that money coming in all the time is by making sure that all this follows uh, um, frequently and efficiently. So we talk about the revenue cycle being uh, when things start at the scheduling or the appointment of the patient. Um, there's no payment for scheduling an appointment. If the patient schedules an appointment and does not show up to the appointment, then technically nothing happened because there's nothing that you can bill for. So I want you to, even though again you've probably seen in your personal or in your personal life, let's say that when you don't show up to an appointment, they might charge you some amount of money. It's because they can, but they should not. So don't just know that an appointment, a missed appointment, does not meet the requirement of a service rendered. So because it's not a service rendered, you cannot bill for that. So you schedule the appointment, then you have a patient registration. More and more patient registration is happening through the internet or through um, a kiosk or something that's not an actual secretary there, but it could happen. Then we have the charge capture. So that's when we have a super bill that says what are we billing for. Under there, we're gonna have not only the charges, we're gonna have the codes for diagnosis, service, or procedures, and then we're gonna have a collection of the payment uh, that the patient has to pay at that time. In this case, is a co-payment, for example. Then we're gonna have post the charges and the patient payments in the patient's account. Then we're gonna create and submit the claim form. We're gonna send it to the insurance company. The insurance company is going to send payment back, hopefully, and that will be it. Or we will have to appeal, then charge or bill the patient whatever is left over. That could be an example of co-insurance. And then we have the to post the patient's payment. If not, we have to go all the way to collections, and then we post all the collection payments. So that is um, the whole revenue cycle. So it starts with the um, the appointment for the patient. You schedule the appointment, and then goes all the way to the last payment. Now, not all of them have collection payment. Not all of them have patient payments. So it could end at and not all of them have appeal. So it could end here at insurance payment posting. So if the insurance pays 100%, that's it. Like that's the whole thing. But again, remember the little map. We have to go through the whole thing, starting from scheduling the patient and finishing in what's the patient responsibility. So one of the things that I want you to understand is that many of the errors committed in medical billing are what we call uh, human errors. The a few examples that we have here. We have front office errors. Those are when the patient has a wrong uh, data enter in their system. They do not have the insurance. They're not eligible for the insurance at that time. So while you are in the back uh, waiting for the information in the front has to be correct. That's kind of one of the problems that we have is that in the front end does not know what information is important, how to manage all that information, and a simple question that they ask is, "What insurance do you have?" And most of the conversations between potential patients start with, "What insurance do you have?" If a patient calls an office and says, I want to be seen by the doctor," the first question that goes to them is, "What insurance do you have?" If they have an insurance that where the doctor is a participating provider, then you can see the patient. If not, then you say, "We do not take that insurance," and at that point, either the patient goes somewhere else or the patient decides to pay out of pocket. So if we don't get that one right, then when it gets to you, then, and again, you pass through all the system. You are the last one that gets the information. Um, then you don't have the information that was needed. You couldn't see the patient. There's no one that you can send the bill to. The same thing with any mistakes on dates, on numbers. Um, you put in the wrong code for or not even code, the ID for the patient. If you get it wrong, you'll be surprised how many times uh, you get papers with no information or information missing. So anything that is not there from the front end standpoint will affect the billing. Now, then the second mistakes that you can find is billing coding errors, and that simple codes that are supposed to be linked together are not. You link a code for fracture and one for an X-ray. That sounds a while, right? But if you do it incorrectly, then they don't link. Then you have a fracture and an EKG. Well, then that's a billing or coding error. You bill for something that is female only on a male patient. That is a linkage problem. It's not gonna fly. The other thing is pre-authorization. So you might think that pre-authorization or authorizations are gonna be done by the front, and that's correct. Most of the time, the front end is the ones that's gonna deal with that. Uh, to their credit, whatever knowledge they have, it's what's gonna be there. If they don't know how things should be, then you should help. One of the most important things is sending medical records. So because you are going to be in the billing department and the medical record department, you are going to keep maintain and perform audits on that. So you will be the one that will help with those pre-authorizations. Um, and if you don't have it uh, before the services were rendered, then you cannot get them, and that's going to be a billing mistake that procedure might not get paid. And you have to be really careful with those things. Like services are not going to get paid for little tiny mistakes like this one that you cannot fix. Back office error. So now it's documentation error, missing incomplete and counterform documentation, and the number one problem that we have for medical billing errors is date, date of service. Date of service is the number one uh, problem. Missing date of service, incorrect date of service, any of those things are gonna be affected. So one of the most important things that I want you is, again, when you see something that has this circle here with the money, it has to do with reimbursement. The word reimbursement is to get paid for something that was done. So something was done in advance. We did a surgery, we did a procedure, we put the patient on a cast, whatever it was that we did, whatever procedure we did, we need to get paid for it. So we're gonna get paid after the fact. So our most important word is reimbursement. Reimbursement is what we're looking for all the time. Let me see if I could do a little pointer or something because I want yes. So I'm gonna put it on the channel. Hello, hello, and yes. There you go. Does this help? Let me see. This help a little bit better for you to see where I am, maybe. Uh, this information, it's you do not have this information yet. This information is my private, paid by me study guide from the NHA. You're gonna get some of this information soon enough, but I really wanna go over it first. Okay, so I will be able to get you this information little by little as we move along. So you do not have it yet. Okay, so the other thing, like we said, is every time we have a word like this, it's gonna have uh, uh, something that we could click on it. In this case, it's revenue cycle management, the process that healthcare providers use to manage financial viability by increasing revenue, improving cash flow from registration to final payment. So I like this line here from registration to final payment. That is the revenue cycle, and then how you manage that. So again, that's just a definition, not probably something that they're gonna ask you guys. Now, so the basic steps on the revenue cycle, we're gonna go over them now. Number one is registration and scheduling. Like I said, some of them are going to be Jesus Christ. Okay, so I will the people that put something in the chat, I'll talk to you guys later. But yes, I read it. No, that's okay. That's okay. So registration and scheduling. Most of the places now have direct registration and scheduling that the patient can actually do it. As we move along, many of the places are gonna go really, really technical with this stuff. Uh, and again, by matching uh, the the registration, the scheduling to a computer and to the patient, then it frees up time for uh, the other things that we need to do. Now, patient checking is when the individual gets to the date of the service. And at that point, we're gonna check a few things. And one of the things that we're gonna check is co-payment. So this is a definition for co-payment. You've seen many of them, but let's add one more. It's a flat, fixed amount that a patient pays for services, for specific services. Example, office or emergency department encounters. So co-payment is a specific amount of money that you have to pay at every visit that accompanies the payment. So it's not included in the payment; it accompanies the payment. Um, the patient registration forms are gonna be given to the patient, and one of the documents that we're gonna give in the patient registration form is the assignment of benefits. And the assignment of benefits, we've seen it in the CMS 1500 form. There's a part in the CMS 1500 form all the way to the bottom that talks about the assignment of benefits if they accept the assignment, and if they sign the assignment, and if the provider accepts the assignment of benefits is the method that the patient is requesting their claim to of benefits to be paid to the healthcare organization or provider that provided those services. So I'm saying I'm getting these benefits, Medicare benefits, but I'm gonna give them to the provider for the services that they render. That way, or by definition, what we're saying is that the insurance company is gonna get paid directly to the provider. It's gonna pay directly to the provider. Another document that they're gonna give you at patient check-in is the Health Insurance Portability and Accountability Act, or HIPAA. It's a federal act that governs and mandates regulations that include um, privacy, confidentiality, security for health care information. That is, again, if you've been, any of you have been to the hospital or to a doctor's office ever, that document you have to sign it, acknowledgement for HIPAA um, um, notification. We need to figure out what the patient is, who they say they are. With that, we're gonna check with um, the insurance card or any document that identifies the patient and with that insurance. Usually, we call them beneficiaries if we're talking about uh, anyone that has benefits from an insurance company. So, beneficiary will be anyone eligible to receive benefits for covered health care services rendered. And the other word that is important is eligibility. So the process to verify if the patient has insurance coverage and has benefits for the service to be provided. So before the services is provided, we're gonna check that you are that you receive benefits and that you're eligible for whatever we're going to do that day. And again, there we're gonna get information on name, date of birth, and ID. At the time, we're gonna figure out a few other things, and those things that we're gonna figure out is other type of payments. For example, out-of-pocket payments is the responsibility for the from the patient. So that could be a portion of health insurance plan defined by the payer. It could be deductible, co-payment, co-insurance amounts, and then definition for all of them co-insurance, it's a predetermined percentage. So co-insurance is the percentage that the patient is responsible to pay for covered services once the annual deductible has been met. And this is very important. Deductible have to be met first, and then co-insurance and the insurance company kicks in. Deductible is an annual amount that the patient must pay before the insurance will begin to pay for cover benefits. Kind of the same principle again. And seriously, and um, all of them are under the patient responsibility. Utilization management it's a method used to control health care costs by reviewing the appropriate and medical necessity of services rendered by patients prior to the treatment being performed. So, are we going to approve that? Then that's part of utilization management. If you go all the way to the top, and we see the our little roadmap here, we have registration, we have patient check-in, and then utilization management review. We see if whatever we're going to do, it's okay to do, and its medical necessity is proven and documented. So let's go now to pre-authorization. So pre-authorization or referrals, a process of requesting approval for a service or procedure by providing medical history to the insurance to support the medical need for the service or procedure. So pre-authorization is asking, hey, are you going to cover this? Okay. Pre-certification is the process of determining if the patient cover details for care services. So what do the what does the insurance company will cover? That is a pre-certification. So that's basically checking what does it cover. Pre-authorization is saying, hey, I want this. Would it get paid? Yes or no? And for that, we need to screen for medical necessity. And if you remember, medical necessity means that you provide a diagnosis that supports the services rendered to the patient. So coding for something that is medically necessary involves association of applicable diagnosis codes to services or procedures codes within the billing software, which is referred to as link or linkage. So you cannot have a specific procedure without a specific um, diagnosis, ICD-10, for example. And most of the things are done by the computer, but still, you need to understand how that kind of works. The next thing is and is healthcare encounter and documentation. So remember, we have an encounter form, or we have a document that captures diagnosis, procedures, place of service, date of service, everything. It could be electronic or it could be paper format. Usually, doctors' offices will have a little tiny table in like one piece of paper that has every single thing. We call that a super bill. And encounter forms are gonna be like receipts for what happened, when it happened, and why it happened. So we are going to enroll the codes there. We're gonna use CPT, HECPICS, uh, ICD-10 codes, and we're gonna have modifiers added to it if they are needed. Perfect example here is patient comes from a routine follow-up for hypertension. During the encounter, reports ongoing cough, um, and the provider orders a chest X-ray to determine that is bronchitis. In this case, the CPT code for chest X-ray should be linked to the ICD code from bronchitis, um, because if not, the hypertension is not uh, a linkable code for an X-ray. Like just because you have a high blood pressure, you should not get an X-ray. So because we figured out something else, we did the X-ray and we did the bronchitis, those two go together. That is medical necessity. That is proven medical necessity, and we can code and bill for those two. Sometimes, and this is our friend Billy here, she said that additional review for patient demographics and insurance information as a step ensures clean claim and reduces denials due to missing or outdated information. Remember, a clean claim is a claim that has every single thing that it needs in order to get paid. Clean claims are going to get paid or denied. Now, they even though they have all the information that they need to get paid, they might still get denied for any other reason. A dirty claim is one that is going to be rejected because it does not have all the information that it needs. So clean claims will get paid or denied. Dirty claims are going to get rejected. Clean claims that get denied, you can uh, appeal, and dirty claims that are rejected, you can fix and resubmit. After the patient goes through the doctor's office, the services, they're going to go to what we call the checkout. In that one, we are going to look for what the procedures were and if the individual has any extra payments. Example of those extra payments could be anything from deductible, uh, co-insurance, or non-covered services, and also what's going to happen afterwards. So any signatures that's missing, any follow-up appointments, anything like that will be done at checkout. After that, after the patient comes out of the office or after checkout, technically you can say that that's when billing starts because that's when you guys are going to start doing the thing. You're going to have you're going to create the claim by taking the charges and putting it in the computer. Remember, you have the um, 837P, P for professional, so this is the same one as the CMS 1500. If you do it in the computer, it's going to be the 837P. If you do it in paper, it's going to be the CMS 1500 form. And remember, CMS stands for Centers for Medicare and Medicaid Services. And they are going to, the CMS 1500 form will be the form that will be sent to the payers to see if they are going to pay for it. At that point, the payer is going to do what we call a payer adjudication. Is when the payer or the insurance company is going to review the claim and reimburse or pay for the allowed contracted amount or allowed amount, and apply charges to deductible, co-payment, co-insurance, whatever it is. At that point, the provider receives the provider will receive payment between 10 to 30 days from claim submission if everything is correct. Um, 14 days for Medicare and Medicaid, and then anything in between 10 and 30 for the other ones. No, that doesn't mean that you have 10 to 30 days to send it. You have 30 to 45 days for insurance for private insurances, and you have 1 year for Blue Cross Blue Shield, Medicare, or Medicaid to submit a claim. Then you're gonna receive the payment. You're gonna post it in the patient's account, and at that point, you need to match the remittance advice or the EOB explanation of benefits, and that's the math portion that we did kind of at the beginning of the class that we are going to go over next week again, and have any money that goes into the account, put it in, and then whatever it's still owed will show in what we said at the beginning, accounts receivable. If for whatever reason the claim was denied, um, it says here that a claim denied can be corrected or appealed. You cannot correct. I don't like this because it's denied claims cannot be corrected. Denied claims are denied. They can only be appealed. So if a claim is rejected, then you can correct it and resubmit. But denied claims are going to be appealed. Maybe you're missing a document. Maybe you're missing a number. Maybe whatever it is. There's a few sections to the or escalation, sorry, to the appeals process. So it could be something that the patient was missing, or the provider missed, or whatever it is, and then you have to prove that you have it, that it was not an error or something incorrect. So you could go all the way to the medical contractors or to the insurance company and get to lawyers and judicial system. It could go all the way uh, to the Supreme Court of the United States. So there is a process. The simplest way is you're missing something, you send it again with the denial and whatever you were missing. You prove that you can have it, you had it from before, and it will get paid. At After that, then you check for patient responsibility collections and payment posting. So if there's anything that the EOB or the remittance advice says that you should collect and it's not collected yet, then you need to collect it from the patient if that's the case. Uh, you cannot go crazy in um, asking for money, so you have to go through aging reports. So that's gonna tell you what things are owed and how long it has been since payment or when the payment is due, and then you have to follow the Fair Debt Collection Act. You cannot go crazy and say, oh, I'm gonna break your legs if you don't pay. It's kind of a different way. And if anything does not get paid, you can send it to collections, and then collections. You can sell that account to collections, and collections will try to collect that money. Now, one of the things that you need to understand is that in order to do this, uh, you have to match what's fair in the industry following those practices. Go to the next one. Okay, so here we're gonna have a few things. Uh, in this case, we're gonna talk about communication. And again, there's no questions on this for the exam, but just know that for you guys, um, one of the most important things in communication, you are not going to be in the front. You are not going to be following what's happening with each patient as they move along through the office. You're going to be at the back receiving the information, the documents. So, yes, you need to know what's happening in the front, and this is where the communication comes in. You need to know that you have specific providers or third party payers or insurance companies that require specific things. So if you know that, for example, Simply Healthcare asks for a referral before a provider that is a specialist sees that patient, then you need to communicate that to the front end and say, hey, we can now see a patient uh, that does not come from a referral, for example. And then you can get the referral immediately if you have a good communication with other doctors' offices or stuff like that. But it might take longer. So you need to let the people in the front know how and what is it that you need in order for that to get paid. It's not only that the patient went there and the things were done and that's it. No, no, no. You need to specific things, so the individuals in the front need to know that. Also the doctors, also the medical assistants, the nurses, they tend to work fast, and again, I'm not saying that they are the ones that get the most wrong, but they are the ones that work the fastest. And by working fast, some things are not as clean or as perfect as they should be. Any mistakes, any things, any opportunities for you to avoid mistakes, you should take advantage of them. And the way you do it is by communicating what is it that they need. So one of the information that the front end needs to know is about billing. It's about specific things for specific insurance companies. Sometimes the patient is one of the best to get things. For example, if a patient needs a referral from their PCP, they could go and get it. They could just go and say, "Hey, I need you to get your referral from your primary doctor," and they will go, they will get it, they will know who to call. Uh, they'll say whatever they need. So again, communication between the doctor, between the clinical, between the front, between the patient and you and everyone, and the insurance company also. It's a thing that is going to help the most for you guys to actually get the amount of money that is there to be reimbursed. Now, this section says stakeholders, and it has a little signal here for money. So the who are going to be the people or the entities that have to do with this? So the money. Anyone. So patient, provider, third party payers, insurance companies, policymakers, like anyone that has to do with healthcare. You know what the patient is. You know what the provider is. This is a word that we throw a lot. Third party payers. Third party payers means health insurance, healthcare insurance company that reimburses services provided by and or health care organization. So services are going to be provided to the patients are going to be provided by a provider, and that's always my little drawing here. I'm going to do it on top of this. Maybe it will work. You will be able to see it. So I always do my little patient, insurance company, provider, and I do my little triangle. Okay, that's the people involved. Now, of course, there's laws in between and stuff like that. But if those three individuals or those three entities have contract with each other, then we will have reimbursement. If any of those links is broken for whatever reason, because the patient does not have insurance with that participating provider, or that participating provider does not have, or is not a participating provider, so that provider does not have a contract with the insurance company, then there's no payment. And again, it's all about reimbursement. So when we talk about third-party payers, is always who is going to pay on behalf of whomever is receiving the services. So if you get into a car accident, the third-party payer will be the the car insurance for the individual that crashed into you, or was responsible for car accident. If you fall in Walmart, then you are the first party. The second party will be Walmart. The third party will be Walmart's insurance because you fell at their place. So that's something that needed to be said. Uh, Data users or uses the information that is going to be used has to uh, has to be kept for as an example. CMS says that you providers should retain health insurance claims for 6 years. Depends on the part or the place that they go. For other places is 3 years, 5 years, so 3, 5, or 6 years, and that uh, is that requirement is for everyone that is a covered entity. And then a definition for covered entity is an entity that transmits health information in electronic form. Providers, health plans, clearinghouses, anyone that provides a service, anyone that pays for a service, or anyone that is in between. Okay, so uh, these individuals have to keep documents for 3, 5, or 6 years, and after the patient is not longer a patient. So if a patient dies or expires, then at least in Florida, 3 years after that. If the patient is inactive, then 3 years after that. So for a patient to be inactive is 3 years of not being there, and then 3 years later. So that's where the 6 years come to be. Some different specialties will say 5 years, so it will be 3 years plus five, so that will take it to 8. So again, most um, of the claims and the information will be uh, kept for many years, up to 10 years in some examples. Now, in order to um, keep them, then we need to know what type of information do we have, if it's electronic, if it's paper, and how are we going to keep it. The same is how are we going to destroy it if we don't, if we're going to get rid of it. So anything is has to be in a HIPAA compliant way. So shredding, burning, again, not burning in the back of the building, but um, there's um, services that are going to take the documents if they're in paper, and they are going to burn them or recycle them by shredding them and making it into pizza boxes. Actually, that's one of the slogans for one of the companies that does it. What type of information do you have? What type of data do you have? Well, you have three types of data that has to do with us. Uh, Number one is the what we call physical data. This is the information that's there, and then it's going to be divided into administrative and clinical. So administrative use for the data will be when we use things to move through the office. So I always give an example of an office. So the information that is given to the front end was gonna move that information to the clinical aspect, and then we're gonna go to the back end to the billing and coding, and then we're gonna send it um, to the insurance company. That is administrative uses of that information. So anything that has to do with quality improvement, management, cost, reimbursement, any of those things, and anything that has to do with the patient demographics, clinical data, insurance, all that could be used for administrative purposes. There's other section that is called clinical data, and the clinical data is now what the individual actually has, what they have, what is done, and all those things are going to be passed through statistics just to make sure that we are doing what we're supposed to do, that healthcare organizations and the states are doing what's best for the individual. So that's part of the clinical. So again, we're gonna divide all the things that happen into what happens inside the office uh, for administration or what we use for clinical. Remember, in order to move that information, there's something called TPO, treatment, payment, or operations, and that talks about the two uses, administrative or clinical, of that information. How are we going to keep that information? We're going to keep it by having it in either paper or digital format. If we have it in paper, then we use files, and they have to be stored uh, in a locked room out of sight of anyone that could pass by it. Only will be handled by individuals that are uh, into that office, or again for treatment, payment, or operations. You could have it digital. So when it's digital, it could be in a specific server in close Ethernet connection between the office or the hospital. For example, Baptist has its own server for anything that's not medical, and then another one for anything that's medical, plus a backup for all the information in digital. Plus, they have a big vault where they have a bunch of other paper documents. So they have like 3, 4 ways of having the information secured in case something happens. The other thing is how are we going to transmit that information? So we have the electronic data interchange. It's the computer technology that lets us exchange information between healthcare providers and payers, or healthcare providers and other healthcare providers, including patients and healthcare providers, or patients and uh, insurance companies. So how we communicate, and again for that we have HIPAA laws that we're going to talk in a little bit, that has to do with confidentiality, privacy, and security, in order to keep that electronic data private, secure, and confidential. There's some things that we need to report, and there's that are specific to, let's say, public health, for example. So you have to report that. There's some quality control things that we need to do that are gonna be also needed to be reported. Most of the statistics that we do are going to be with what we call non-identifiable information. So there's some information that does not have the you cannot identify the patient. So I could be talking about a patient that had high blood pressure and had a broken leg and had an X-ray. We don't need to know what patient that is, but we know that that's happening, for example. That's something that we're going to do. There's some medication. There's some, to give you an example, COVID-19 for all the way until a couple of weeks ago, I want to say. It was a reportable disease. So whenever anyone tested positive, they had to report that to the Department of Health, um, and uh, some other diseases are like that. So if you have to report it, again, you do it. That's through non-identifiable information. Here's something interesting. HIPAA says not only protect the health information (PHI) in electronic or paper, but also protect the information in the verbal form. So if you are talking to an individual, you need to make sure that the conversation is in a private, nobody's overhearing that conversation. The same thing if a paper it's loose or left somewhere that somebody else can read it, that is a violation of HIPAA. So as simple as someone talking, or any breaching in confidentiality could be a HIPAA violation. One of the other things that we are going to talk about is compliance. So anything that has to do with healthcare has to go through the HIPAA guidelines. HIPAA it's uh, regulations through act and legislation. So that is the government, but also they have to follow the state regulations. If you have any problems with that or any violations, it will go through the office of the inspector general, uh, part of the judicial system. So at that point, you will be going in front of a judge to see what you did. The Office of the Inspector General Division of the Department of Health and Human Services, it's the one that's going to be responsible for investigating fraud and abuse. As a definition, fraud is intentional billing for services not performed, reporting fraudulent diagnosis, or medical coding errors. Abuse is going to be billing patterns and practices that are excessive or unnecessary but not fraudulent. So abuse is to lie about doing things. Fraud is lying about doing things. Abuse is just doing things to take advantage. So all of them are wrong, unethical, illegal, and if you get caught doing that, you're gonna be investigated by the Office of the Inspector General, part of the Health and Human Services, part of the federal government, and you can just end up going to jail, losing license, getting fined, like a bunch of other things. In order to make sure that you are doing what's right, we have compliance plans. Every organization will have one. They will have policies and procedures that you have to follow. One of the best uh, suggestions I have, if you see something, say something uh, kind of like that. If you see someone committing fraud, if you see someone submitting things or lying about the things that they're submitting, just go to your immediate supervisor and say, "Hey, I saw this. Is this correct? It looks wrong." And make sure you're not part of it, because if an investigation happens and you knew about it, you are gonna be as responsible as the one who did it. Um, Unfortunately, it happens. It happens too much. Every time you hear on the news, uh, someone went to jail because of Medicaid or Medicare fraud, and it's millions and millions of dollars. Like this is something that happens a lot. And the more that happens, the worse it gets, because we are the ones that are paying for them. So this is money that comes from our pocket. We are getting taking money away from our contributions to it. So the more expensive it gets, the worse it's gonna get for us when we get to the age of um, Medicare, Medicaid, and again, all of it makes it a really big waste. So other than that, you're gonna be working at this, and it's gonna be really hard to get a job after you get convicted of Medicare fraud. So the Office of the Inspector General has a few things that you should do. One of the things is internal audits. So let's check what we're doing. Implementing compliance practices standards. Designating a compliance officer. Many of the places that you're gonna work, you will be the compliance officer. So the one that works with billing and coding is the one that usually gets the title of a compliance officer. Um, then, because you're the compliance officer, you need to train and educate the staff, uh, look and detect violations, and just check that you're doing things correctly. And again, just meeting with the staff, communicating with the community, uh, and know what's happening in the compliance, and then enforcing the disciplinary standards through the well-publicized guidelines. Uh, Many of the places that you're gonna end up working, they have a strict policy on this. If you are even suspected of committing fraud or abuse, you will be terminated immediately. Uh, Again, the fines are so steep that it makes no sense for a small office to get caught into this. So they will fire. the individual. Um, if you do something wrong or something kind of happens, um, and say, hey, I think this is wrong. I think we've been doing this, and now we figure it out. There's a self disclosure thing. It's a voluntary uh, disclosure of what happened, and helps in the investigation, and just make sure that what you did wasn't horrible. And if there's any fines to be dealt, it will be a lot lesser than if they actually discover it, and then you get caught. So as simple as not making any mistake uh, will help you with this. So many of the things that we do can uh, be wrong, or can be looked at something wrong. To give you an example, if I say, hey, we saw this patient today, today is 7/18, and then we forgot to get the pre-authorization, and then you say, hey, we got the pre-authorization, we got it on the 19th, or has date of the 19th. Can we change the date of service to the 19th? It's just one more day. And for someone that is not well versed on this, might say, what's this, a day changes? So okay, we say that we did it on the 19th. We have the document for the 19th. We send it, and that's it. Well, you're saying that you did something a different date of the date that you did it, and that's fraud. That's lying about it. That simple thing that seems like it's nothing, it could become a pattern, and we could say, hey, the secretary that was there always does that. She will just change the date to the next day or whatever. Um, and there could be months and months and many uh, uh, different bills, different claims that have it. And I've seen that happen. I saw one time a secretary that will say she would never ask for a referral or for a pre-authorization. She will see the patient gets here, we'll do it. The correct thing will be, hey, patient, let's get this first, and then you come tomorrow. But she never decided to do that. She said, hey, it's better if I, after the fact, get it, and then I just change the dates. And she was doing that for like around 6, 7 months. So imagine how many times they did that. So there was an investigation because someone disputed the date. They say, hey, I was there on the 18th, not the 19th. I want to make sure that this is right, whatever. They went back and checked, and they did a little investigation, um, and yes, all those claims were paid. All those claims were fraudulent because they were lying about it, um, and it ended up in a $500,000 fine for the office. So something that was done kind of in good faith. So the secretary said, hey, to help the patient, they don't have to come twice. To help the doctor, so they, you know, to, for things to get paid or whatever. It became a problem. Now the biller didn't saw it because they were just seeing the claims kind of the 2 days after the fact, and they just thought nothing about it. And it was a big thing. So, needless to say, the lady, the biller, the office manager, a bunch of people lost their job, um, and there was a big $500,000 fine to a tiny doctor's office, just because something of that nature. So you have to be careful with those things. Another thing that we have is confidentiality, security, privacy, and all those things based on HIPAA. Confidentiality is to protect the patient's information, to keep it confidential, so nobody that is not allowed to see it sees it. Security is the protection of that confidentiality of that information, to keep it in a way that it's always protected. So the way that we could do both things. Security is again encryption, passwords, logging logs to see who logged at what time, what did they look. So most of the softwares that we have will have those things embedded in order to keep things, secure and confidential. Now, another thing that we have is privacy. So privacy is a little bit different than security and confidentiality. So one of the when we talk about privacy, we say that we need to maintain privacy to the minimum necessary standard. So, cover entities again, so anyone that handles protected health information has to make sure that the disclosure of information of protected health information is appropriate to the rule. So, the minimum necessary standard requires employees to be limited to the information that they get, limited to the area that they can get, only in a need to know basis. And I always ask the question: does the secretary need to know the the procedure or the ICD diagnostic code for the patient? Not necessarily. Uh, does the doctor or the nurse or the medical assistant need to know what type of insurance the patient has? Not necessarily. But in your case, the biller and coder needs to know that information. Needs to know what the diagnosis was, what the procedure was, what the insurance was, like all the information that is compiled on that patient is on the need to know basis of the builder. But the front end and then the clinical side might not. So in your case, you are required to see more information than nobody else. So that's okay. But the front end should not have the same uh, the same accessibility to the information than you have. So that's something that you need to make sure to understand, because when you end up working at a place that they're giving kind of the same code to a computer to everyone, then nobody knows who has access to what, and that could be a breach in privacy, security, or confidentiality. A few examples of breaches of confidentiality. So, communicating patient information in public areas, a lobby, an elevator, or cafeteria, screaming out, hey, this patient has this or whatever by name. Disclosing patient information in unattended areas, kind of the same thing. You're leaving information in paper, a computer open with the information on the patient, all those things. Disclosing patient information without the patient's consent to any members of their family or friends. So someone comes in and says, "Hey, my spouse was here. I need to know what her diagnosis was, what the procedure was," um, and not checking if they are authorized or not. That could be a breaching confidentiality. Uh, Announcing patient information in the waiting room or registration areas. So the easiest way to think about this is you're gonna call the patient by first name. Um, Usually that helps. So you go and say Mr. John, and then Mr. John comes to the door, and you go like, okay, pass by, and then you ask the questions after, like before, like beyond the door. You don't say, "Hey, Mr. John Smith, the one that has cancer, can you come to the?" Like again, it's sometimes it's common sense, but sometimes it's not that common sense. So make sure that you know what you are saying, what you can say, what you cannot say. Um, and again, in your case, you're gonna talk to patients kind of in the back, so it's always like you're gonna call them in and say, "Hey, let's talk about your billing questions or your payments or whatever it is." Try never to do that co-payment, co-insurance talk in front of other patients, because other patients might have different insurances, and usually they have different insurances or even different plans inside the same insurance company. So you have to be careful of those things. Uh, what is um, what is protected health information? Anything that has to do with the patient. Anything that has to do with the patient. And what I mean anything is anything. Every single thing. A picture of the patient, the name, the social security number, where do they live, where do they work, Do they drink coffee? Do they do cocaine? Or like anything will be uh, uh, part of the protected health information, and it's not you're not allowed to move that information without the consent of the patient. Let me check real quick. 110. Check Andrea, Christian, Frank, Selene, Amiga, Marta, Monique, Mita, Frank, Danny, Vanessa. Okay. Next part will be the privacy rule. So the privacy rule is um, the the regulations like for confidentiality and security that ensure that the patient have the control of their health information, how it's used, and who can see it. For that, we have release of information. So I always, whenever I explain this, I wanna start with saying you are not going to release information unless someone requests that information, right? So why would you release some information on a patient? Because someone asked for that information. So someone's gonna say, "Hey, Andrea, remember me from school? Yeah. We took that billing class together. I know that you work for Doctor So and So. I need information on Cristian González as a patient of yours." Okay. So Andrea's gonna say, "Okay, so you need to send me official requests of information, of patient information, and then I need to get the patient to sign a release of information. With that, then I can give you the information." So the privacy rule talks about the release of information. Again, it comes after a request for medical records. And here they have an example. Here, you see it opens, and if you can see it, it opened, but you won't be able to see it until I. It's taking a while, but it's opening. Let's see. There you go. It works. Okay, so I'm gonna change this one to this one real quick. There you go. Okay, so this is an example of HIPAA authorization for use for disclosure of health information. You will have the patient's name, and this is important that it has the patient's name, date of birth, and social security number or medical record number or something like that. Authorization to disclose to who. So this is going to be who's requesting it. All my health information, some of it, and it will take what information it is. My health information from this date to this date, or other. It could be results. It could be something like that. The other party discloses my information to the following recipient, and you see who is going to get that information, what, and then the authorization ends on a specific date or when this happens. Again, after submission, this is not an open authorization that you can do all the time. Signature of the patient, date, if the patient is a minor or the patient is unable to sign, somebody else, and then the representative for the legal guardian, who is it? And some other things will say for physical abuse, alcoholism, drug abuse, I consent or not to send the information, and also for HIV/AIDS. So this is gonna be different in every single place. So it might be uh, with the letterhead for the place that you work for. It could have a bunch of other things there, but that's an example of a really simple one. Most of the places are gonna have anything that looks like that is kind of modified uh, to the practice. So it was gonna have the identification of the organization and the patient, so the doctor's office and the patient, the time frame, additional uh, time or when it's going to end, information to be released, the purpose of the request, date of the request, and then signature, original signature. So for privacy, we need for for the privacy rule, the release of information has to be signed by the patient. Okay, so it has to be signed. It's really important. Now, consent is a little bit different. Release of information requires consent of that release of information, but consent is when we give permission for something. Okay, it could be for the disclosure of information, or it could be uh, um, uh, something else. So in the clinic part of it, we have implied consent, informed consent, and written consent. Implied consent is the example is you go to a nurse or medical assistant and they say I'm gonna draw your blood or I'm gonna check your vitals, and then you extend your arm so they can actually poke you, or they could put the tourniquet or the pressure cuff in order to check your vitals. You are giving consent, and it's implied that you're giving consent because you are extending your arm. You are going through the motions of getting that thing done. If you were going to do something that is a lot more risky, or like an example, surgery, then you will need informed consent in order for you to agree with it. Okay, so and they're gonna say, hey, this is what we want to do. This is what we can happen if we do this. This is another option. This is what can happen with this second option. You could do nothing, and this can happen if you do nothing. And you know, again, and then you say yes or no to it. But not only say yes or no, you have to sign it. So written consent is when the procedure has a significant risk or complication, then you need to sign it. So for to do, for example, stitches, then there's an informed consent. They explain we need to suture this before you die. But if it were to be surgery, then you will have a written consent that you have to explain those things plus sign it. So consent is permission to do something or go with something. Here we have the TPO, treatment, payment, or operations. I've been talking about this since day one. For treatment, payment, or operations, we do not need a release of information signature. Okay, I don't need the patient to sign a document that says we are going to move your information around. So this means that without the patient permission, even though it's an implied permission, we're going to move the information around. For example, for treatment. So the vital signs are going to be uh, um, done by the medical assistant. They're going to send it to the nurse, and the nurse is going to review them, and it's going to forward them to the doctor. Like, we don't need to tell the patient, hey, we're going to move this information around because it's for treatment. For payment, kind of the same thing. After the patient leaves, you prepare the bill and you send it to the insurance company. You don't need the permission from the patient to submit that information to the third party payer. An operation, again, anything that is in between, from the front end to the clinical part, from the clinical part back to the front desk, from the front desk back uh, to the biller. Like, I don't need to tell the patient or ask for the patient permission in order to do that. It's kind of implied, but it's just, it's a specific permission that the covered entity has, as long as they're following treatment payment operations, that they do not require the patient's permission in order to move their information around. There's some few exceptions, and I think they're really interesting. There's always one question on your exam about this. So there's two scenarios. One, it's a legal one, and the other one is Um, they're medical ones. So the legal one is simple. If the court, civil or criminal law, asks for your documentation for whatever reason, they're gonna get it without your permission. Okay. So if for whatever court case is happening, they request your medical records, then you cannot uh, deny, or nobody's gonna even ask you. Okay, they're gonna ask the owner of the medical record, that in this case is a provider, and say we need copies of this. So that's something interesting. The patient does not own the medical record. The medical record is owned by the creator of that medical record, so the provider is the owner of the medical record. Um, so that's legal. That's it. The rest is clinical. So emergency, um, excuse me, emergency situations. We might open the medical records. We're not gonna say, okay, the patient is unconscious. We need to wait until they wake up to ask if we can see the medical records. No, we're gonna see the medical records. We're gonna try to save their life, and we're gonna move that way. Uh, Psychology, psychiatry, also mental health related records um, are not uh, um, um, are not going to be provided unless it's an emergency. Also, usually mental health records are going to be separated from any other records, just to avoid that. Um, Pregnancy on minors also is going to be protected. So the minor, as a female is pregnant and she's a minor, she is responsible for their medical records, not mom or dad anymore. So mom cannot say, hey, my daughter is 15 years old, she's pregnant, but I'm the mom, I need to see the information. Nope, it's the patient. Um, Substance abuse and HIV/AIDS also have a few things. So some information should be disclosed um, as as to the Department of Health, for example. Um, but other than that, you cannot disclose information uh, to other individuals. Okay, so there's no way you can get that information without the patient consent, like for any reason. And then so anything else will be the same thing. If something has to do with the law will be on top of that. So again, drug alcohol abuse should be kept confidential and not be subject to disclosure. So even if you ask for a patient's HIV status or substance abuse or um, psychiatric evaluations, like those things are not allowed. You cannot ask for those. So security rule is the standard for protecting information as doing few applications, because most of the information now is going to be in electronic form. We have an act that's called the high tech. So high tech for high technology, even though it has nothing to do with it does have to do with high tech, but high tech is an acronym for health information technology for economic and clinical health. So it's kind of a play on words there to say high tech. It has two features to promote the use of electronic health records and to make the HIPAA privacy and security rules from electronic health records a lot stronger. So high tech was came after HIPAA with the kind of globalization of electronic health records, computers, iPads, iPhones, stuff like that, that can handle a lot more information. So that's something that brings the security rule, and it's just being an expansion um, of the changing times from uh, from the beginnings of HIPAA all the way now to what we have now. Regulations uh, for clean claims and accurate billing. So Again, money sign here, a claim uh, that is submitted without any errors, any complications, anything, including incomplete documentation, incomplete information, or anything. Like every single thing that we need is there. It's gonna be considered a clean claim. If you submit a clean claim, you will get paid. If you submit a dirty claim, that claim will be rejected. So one of the the problem is that if you have everything that you need and something is wrong, then it will be denied. And the more you do that, the more it will kind of look like fraud or abuse. So fraud, like we said, we take it, we don't take it really lightly. The Office of the Inspector General is going to say that coding and billing is one of the main areas for fraud investigation. Um, Fraud is billing intentionally for things that are at a lower level and saying a higher level. The perfect example is the 99, so 99213, and then you go like, nope, the 214 is a little bit better. It pays $100 more, and we do that. That is uh, kind of the number one red flag for fraud. Also, double billing, just to try to get paid twice, or unbundling, just using multiple codes for something that it's supposed to be one code. So let's say a code is $150, and then you separate it into two different codes. One pays 100, the other one pays 100. Then you might say, well, I'd rather do that. It pays $200 instead of 150. That is fraud. You're saying that you did something that you didn't do because you did one instead of two. It becomes fraud, not even abuse. Uh, Easier than that, then billing for services that were not performed. That's lying about things. Reporting diagnosis that are fraudulent. So that's not a diagnosis, but we're putting in there so it fits or links to the code that we use for the CPT. That's lying about it too. So that's also fraud. Or what we call purposeful medical coding errors. So you're doing upcoding all the time, all the time, all the time, just to see if it flies and it gets paid. Then because that's on purpose, just to try uh, to lie and see if it gets gonna if it gets paid, and that's fraud. Now, if you keep submitting the same thing and always gets denied, and you don't complain about it, then something's wrong. They're gonna say that as a red flag, and they're gonna ask, "Hey, why are you doing this?" So, if you commit the same error multiple times, uh, they're gonna look for it. They're gonna say, "Hey, Andrea, why do you have all these codes, all these claims that are not getting paid, and no appeal, no complaint, no nothing?" Hopefully, you're doing what you're supposed to do. I can give you an example. I was working at a place once that they didn't had an actual biller for a long time there. So they just had the secretary that knew a little bit about what about billing was, and she was doing something wrong over and over and over again. So I get there, and I get a call from CMS, and they go like, "Hey, we're investigating you for fraud." And I'm like, "Listen, I just got here first of all, number one. Number two, what is the thing? I kind of knew the people, so I knew that they were not gonna do that. Or actually, I thought they were some of them were dumb enough. They were not smart enough to actually commit fraud. They just didn't have the knowledge or the ability to do it. And they said we're gonna do an audit. This is what we're checking. So they asked for a bunch of files. They had all paper files. So I have to go through all the files. I went through a few of them, and I go like, I already know what happened. Um, and I checked. I said, hey, this is what it is. This lady is using this code when we told her to use this one. It's a honest mistake. I can prove it, and we're gonna fix it. So um, it was it was fixed. We were losing a lot of money because those codes were not getting paid because it was the wrong code, but because nobody was checking for those denied claims up until I got there. I had to go back like a year of codes, of claims to get all those codes um, fixed and paid. That was kind of an interesting one. We got not most of them, but we got a bunch of them paid because we still had the time to do the appeals. But what was interesting is that it's not that they wanted to pay it; it's that they wanted to shut us down because they thought we were committing fraud. So it's something that happens. They look for it all the time, and as simple as making the same mistake over and over and over and over again without you know without complaining, then that means that either you're doing it on purpose, or in our case, nobody was paying attention. So anything that doesn't get paid, you figure out why, and you try to fix it or appeal it, or you just you know you make sure that you get that money. So it doesn't look like you're doing anything wrong because you shouldn't. Abuse is when we are doing things that are excessive or unnecessary. So uh, one of the best examples is you uh, um, send the patient uh, um, appointments really close to each other. So appointment every week. No one needs an appointment every week, uh, but you do it. You send the patient an appointment, and they go like on Monday, and then they come next Monday and next Monday. So they come 3 times in a row. Um, you actually saw the patient, but that is uh, that is wrong. So one of the ways that they fix it is by either taking your money back or not, or putting you like in a balance. So you owe them some money, but whenever you send the next claim, they'll keep the money. Medicare will not play. Medicare will just they have a way of depositing the money into the bank account for the provider, and they also have a way of putting their hands in and removing that money if it was an overpayment, for example. Anything that is not medically necessary, it's gonna be considered abuse. So you have to be careful with those things. Anything that you do that it's considered fraud or abuse will be investigated. In order to prevent that, the number one thing to do is do it. Uh, be on top of things. Accurate, timely documentation, appropriate link of the procedures and the diagnosis, the code assignments, correct provider referring physician information, including the claim, correct service date. If you use the incorrect service date on purpose or not on purpose, but knowingly, that could be either fraud or abuse. Usually leads to fraud. So, no unbundling, upcoding, any of those things. When you're trying to take advantage or get more money, it's going to be uh, those two things. Unintentional billing coding errors could end up being uh, fraud. Unnecessary charges, abuse. Bidding for non-medically necessary charges, abuse. And again, all those things are going to be uh, punishable by law. When we talk about correct coding, we want to make sure that we do it to get the money. So for reimbursement at the end of the revenue cycle, and to prevent fraud and abuse. There's two ways that we have the codes. Um, the National Correct Coding Initiative, there you go, the NTCI, has programs that are going to make sure that you do this. So this is an example of codes uh, and or codes that need, for example, either uh, uh, modifier or no modifier, or do they have to be together? So any of those things. So they're gonna have different codes, different things in your software that will help. We already know that the code descriptors for CPT or the explanation of it will be what we were looking for. This is an example of a CPT code. Says fine needle aspiration biopsy. So and then it says comma or semicolon without imaging guidance, first lesion. So what you would look for is for biopsy and then fine needle aspiration or biopsy aspiration and then fine needle. Mastectomy, simple, complete. So what you're looking for is mastectomy. You look in the index for both of them, and then you follow and get the codes. Simple. We went over CPT, HICPICS, and ICD. We will go again at the end, close to your to the last days, and with some homework that I have for you guys. Uh, the the claim data or the claim information will come from the encounter form. The encounter form might look like this if you were actually doing it. So patient, the name of the patient, name of the provider, and then establish patient or new patient. You will click on this and it will change whatever they have. Category system if you're looking for. And then here you have the options. As soon as you put established patient, you will start in the 99212. The serials are not going to be there because that will be for new patient. So as long as you follow the information, it's going to be really, really easy for you to get. Okay, so then you go here, nervous system, and you go with the disease of the nervous system. So it's a lot easier than looking a book. But the day of the exam, what they want you is to look in the book. So that's why we learn and practice the way the way we did. The claim formats we know 837P, P for professional. It's the same as the 1500 form, but the CMS 1500 form is um, the paper version of it. Uh, so again, CMS 1500 form or 837P for a doctor's office, clinics, or outpatient services. For inpatient, we have 837I, I for, we can say inpatient or institutional. The electronic form for that will be the UB04, Universal Billing Form from 2004. And those are going to be for inpatient organizations. UB04 form is the paper claim, and 837I is the electronic one. I like this little part of the revenue cycle for the insurance claim. The claim is done first of all, then submitted. It's going to be processed. It's going to have an adjudication. This is how much. This is the decision, and then it's going to have payment. So you create it, you send it, it gets processed, it gets checked, and then paid. If when is checked, the adjudication process ends with a denial, then we're gonna add here a little point here, and it's gonna be for appeals, and then hopefully after appeal we get payment. So you know that the claim is created and is submitted to first goes to a clearinghouse. The clearinghouse is a payer-specific agency that is going to check for the claim being correct. That's where we have the clean claim. They're going to be submitted after they pass the clearinghouse. The clearinghouse says, "Oh, clean, let's pass it." They're going to be in batch. They're going to be by provider usually. They're going to go from the billing and coding specialist to the clearinghouse. From the clearinghouse is going to be verified, and then it's going to be submitted to the payer. So I always want to point that out. From you guys, the billing and coding specialist, to the clearinghouse. If the clearinghouse finds that it's clean, then it's going to send it to the payers, and then the payers are going to adjudicate and pay. If not, if it's rejected, it's going to be sent back to the billing and coding specialist to be fixed, and then go again when it gets clean, clear, and goes through the adjudication. Now, after adjudication, if it gets denied, then you're gonna get it back, and then you have to appeal. You cannot send it through this process again. So this is the thing: denied claim. The cleaning house gets a claim. They say, "Sure, we're good. Let's send it to the insurance company." The insurance company says, "Okay, cool. There's payment." Boom, they send you the payment. Here, denial. So now it says denied and why it's denied, and then it's sent back to the payer to the provider for heal. But in this case, it says rejected. So this is a dirty claim. It's gonna get sent back to be resubmitted, fixed and resubmitted. Examples of denied claims: incorrect policy or patient identification number, so they cannot find the patient, they're not going to even continue. Incorrect diagnosis or procedure, incorrect service date, incorrect year reported on claim, lack of place of service. Like if it's missing any of those things, denial immediately. Like they're not going to tell you that it's wrong. It's just a denial. Calculating errors, charge amount balance errors, coverage, the service is not covered, the patient is not covered by the policy at the service time. That happens a lot. If you do not check that the patient has a valid insurance at the time of the visit, then you might be sending something to someone that does not have a contract with the patient anymore. That happens a lot. Not medical necessary. That happens also quite often if you didn't check if it was they're gonna pay or not. And then pre-authorization or pre-certification not secured before the service date. So this, I want to say that this last four are the most important ones because you could check this beforehand. You could check if the service is covered. Check if the patient has an insurance. You have to verify eligibility for that patient every single time you perform a service. Check if the procedure is going to be considered medically necessary beforehand, so pre-authorization. And if it requires a pre-authorization or pre-certification, you need to do it beforehand so it gets paid. So that's kind of simple there. One of the things that we might need is medical record audits, and we have the medical record audits to make sure that what we're doing is correct. So the way we do it is we do a retrospective uh, analysis. We go back and see that what we're reporting, what we're doing, what we're supposed to, and it's getting paid. Um, then one of the options is you do it on your own, or you have Medicare, Medicaid do it for you. Medicaid and Medicare are also going to do a retrospective audit. Well, now they're going to check every single thing that you do. It serves for the prospective uh, future to make things a little bit better. It depends where the location is, uh, what, how many areas are gonna check. Usually, doctors' offices in clinics, like the ones that you're gonna end up working for, um, are gonna have an annual uh, um, or semi-annual, maybe 2 times a year audits, internal audits, and they might have one every 2 years from Medicare. So you have to uh, think about that. Hospitals for sure have multiple internal audits, and then quarterly they might have uh, at least one. So they get 3 or 4 a year from Medicare. So audits are really good. Again, Cody here says conducting internal audits is one way of identifying fraud or abuse within the organization. And if you find that within the organization, then you can fix it or report it before they come uh, they come and get you because that's the next thing that's gonna happen. A little summary for this one: the steps in the revenue cycle start in registration. They go to scheduling, patient check-in, utilization management. This is um, medical necessity. Uh, Healthcare encounter, documentation, charge capture, coding, patient checkout, billing, pay adjudication, receiving, posting reimbursement, appeals, claim corrections, patient responsibility, collection, payment and posting. So from the beginning, registration and scheduling, all the way to payment and posting. Um, you are gonna be part of that whole thing. So usually, because you're gonna be the biller encoder, you're gonna be in charge of the electronic health records, and the electronic health record starts with registration and scheduling, patient check-in, also utilization management, also like everything has to do with billing and coding. So you're gonna have the most access to the information, or the actual uh, way of doing things will be done in your way, because you will be the one that understand how is it that we need to do things in order to get paid. So integrating the revenue cycle into healthcare organization means that everyone's gonna work uh, to make sure the flow of the information through the departments are optimal, so we can get the optimal reimbursements um, of patient care and services. Patient verification, billing claims, information use automated approaches to expedite the reimbursement. So even though I keep showing you how to do things in paper, I show you how to look in the books. Uh, that is to get a better understanding, but when you do it in the computer, it's a lot easier. So it's gonna be a lot easier for you guys to do it when you are out there. For the exam, it requires to be done with books, so that's why we're showing you that. Uh, Center for Medicare and Medicaid Services providers are to retain insurance claims for 6 years. Again, 3 years from day of visit, first visit or last visit. 3 years later, that patient will be inactive, and then you have to wait 3 more years. So that's where the 6 years come. Some places require them to be 5 years, so that will be 3 years, and 5 years is going to be 8, or up to 7 years on some specific parts. So it could be all the way to 10 years. The first 3 years, and again, 3 years of a patient being inactive. If the patient is active today and it's not active for the next 3 years, at those 3 years, we have to start counting either 3, 5, or 7 more years. So minimum 6 years, 3 years since the day of last service, 3 more years after that because the patient becomes inactive, then 6 years. In order to uh, get rid of that documentation, you need to do it in a HIPAA compliant way, where we are going to destroy the information, or the in a HIPAA compliant way. If it's paper shredding or incinerating, if it's through the computer, it's through software that is going to erase and certify the erase of that information um, in the electronic form. HIPAA breach notification rule regulates reporting impermissible use or disclosure of protected health information. Any breach of information will be require internal review. Some breaches require higher level of notification. Release of information has to be done in a HIPAA compliant way. The patient has to sign a release of information request form signed by the patient, or by whomever is in charge of that patient. That requires also request for information. So request and then release of that information. Uh, the only time a provider can send records without the patient permission is for treatment, payment, or operation, TPO, treatment, payment, or operations. At that point, we do not have to ask permission for the patient. And then we have the NCCI system. Edit supports correct coding and prevents abusive billing patterns. Basically, what it does is like it will give you the only codes and the only modifiers that you could use when you link some specific things. Uh, all of it is uploaded to the software that you're gonna use, and when you use that software, then it won't let you put wrong codes, linking wrong codes together, so that helps them. And then the last thing here, audits can be performed by comparing encounter notes to all related documentation and codes were billed, the claim, so that's a retrospective audit. And it's internal to make sure that you don't get mistakes, and you avoid fraud and or abuse. I'm gonna go to the glossary real quick to see some of the words or the terms. These are the same terms that we saw during the whole section. So I'm gonna give you most of this information is gonna look a little bit different, but my plan is to show you, uh, give you everything. So I'm gonna upload it by modules. So I'm gonna upload tomorrow morning. I'm gonna upload module one and maybe module two. So when we come back on Thursday, we can see module two, and if it's this one that is bigger than the other one, whatever the two that we're gonna do next class, we're gonna do two, and the Friday we're gonna do one, or maybe we're gonna do all of them, and then Friday we're gonna do something different. Let's see what the where we go from this. I will try to give you all the information that I have. Um, I cannot give you access to this the way that I'm accessing it because this is uh, again copyrighted and paid for by me, or I shouldn't be giving it to you anyways. But I think it's worth like almost $200. So I better it's better if I give it to you guys, if I give you the information, so you don't have to pay for it and still get the information. So this is me kind of
Professor.
getting, yes, this is kind of me getting out of my way to helping you guys a little bit more than what I should. But I still think that is going to be good for you guys. Yes, go ahead.
Professor, when would we be going over the midterm exam?
At the beginning of the class, we said it. I just received one exam that I was missing. I received it today, like at 3 o'clock. I want to say. Uh, so I haven't got a chance to go over it. At 3:48, I got it. So I haven't had time to get through that one, but everybody else is done. So we will probably next class or by the end of the week.
Okay, no problem. Thank you. Because I know
No
you said a
problem.
lot of questions from there would be on the test, right?
Yeah. So all of this that I'm showing you now, all of that plus another one that I'm gonna give you, it's kind of the everything that does not have to do with codes, CPT, HICPIX, or ICD. It's gonna be from that and from this. Okay, so I'll get you as ready as I can. Um, but we still have uh, a few more things to check before we go into like a last stretch of going out. So we're doing good. You guys are doing good. Hopefully you finish strong. Any questions? Anything? I know it's a lot of me talking, but I'll give you this so you can read over it. Um, and yeah, that's it for today. Next class, hopefully I will be able to do the other maybe the other three. Let me see how fast. Not how fast. That's not what I'm looking for. How long they are. Doesn't really matter. We'll probably do uh, two next class and just one on Friday.
Okay, Professor, I have a question regarding the
Oops,
when a
sorry.
patient
Go ahead.
when a patient doesn't meet their let's say that a patient didn't meet their how do you say
Deductible?
the deductible. Yes,
Mm-hmm.
and he's coming for an office visit and he needs to do some procedures. And how does that how do they handle that when
You do it normally. You send it. You send it to the insurance company, and the insurance company is gonna send you back zero payment, and they will say that the whole thing was sent to the deductible, so the patient should have paid for that. So let's say the patient has a deductible